నెట్ చూడు ఒకసారి. Yes, sir. Good afternoon.
Yeah, very good afternoon, sir.
So, shall you wait some time? Sir, we'll start at 2:10.
One second, sir.
We start at 2:10. We'll wait for
Yes, sir.
four,
We'll
four minutes.
start at 2:10. We'll wait for some of those.
Yeah, let's participants will join.
By the time I'll just recap what we have discussing in the morning, so
Yeah,
that by the time they join, we can just
yeah,
continue. So morning we were just discussing about what are the basics of pharmacoeconomics, and followed by we said first two analysis of pharmacoeconomics, which is cost minimization as well as the cost effectiveness analysis. So I just to recap it what we were telling, and in between I just got a query that to just to revise again about ICER calculation as well as the INB. So I'll just talk about that as well. So first we said what is pharmacoeconomics. So basically pharmacoeconomics will relate or connect between cost and the effect of the drug. So that we discussed already very well, and cost minimization analysis where we will be just comparing the difference between two drugs which we believe or we expect to have the same efficacy as well as the safety. There will be only difference in terms of cost. So what we do after doing a cost minimization analysis, which is having lesser cost when compared to the other alternative, we'll be choosing as our drug of choice. And when we go to the cost effectiveness analysis, as we said, we have first what we need to do, we should do a cost consequences analysis. In cost consequences analysis, what we do, we will just classify what, or we just calculate what is the cost of each intervention and what is the outcome of the each intervention. The next step in cost effectiveness analysis is cost effectiveness ratio, which is CER. What we do there, we will calculate how much was the amount of rupee or how much was the cost which has to be paid to get a single average outcome. That's what we do in cost effectiveness analysis. The third step, final one, which I said you is incremental cost effectiveness ratio. So incremental cost effectiveness ratio, what we do, if you have a note in your hand, I mean, if you can write it down somewhere, I'll just the equation for each and every one, then you can easily correlate that. The first one, cost consequences analysis. We won't do any analysis. We will just list out what was the cost of each resources and what was the benefit of each resources, or what was the outcome which we will get from the each drug. Then cost effectiveness ratio, CER. What we do, the total cost for the intervention A divided by total benefit what you got out of the treatment, or total outcomes what you got the treatment is called as cost effectiveness ratio. So now I have cost effectiveness ratio for interventional drug as well as I have cost effectiveness ratio for the comparator. So when we have these two, from this we can calculate the incremental cost effectiveness ratio, and the equation for incremental cost effectiveness ratio, ICER is equal to ICER is equal to cost in intervention minus cost in comparator divided by effect in intervention and effect in comparator, so that we can able to calculate how much amount of money or how much will be the ratio of amount of money has to be paid to get a single interventional new benefit. That is what we can calculate from the ICER. So as I said you before, if I get an ICER in a better way, uh, as I said, in an example of FP versus PA, I just put it up that slide back. Yeah. Can you, is it visible now? Hello?
Yes, it's visible.
Yeah. So you can see that here you can see the cost per additional SFD. The first line, that is the calculation for CER, cost effectiveness ratio, average cost effectiveness ratio. That means to get a single SFD, you have to pay 14 rupees of amount or whatever it is to get a single SFT, that is called it as cost effectiveness ratio. When you do incremental cost effectiveness ratio, what you need to do, you have to calculate difference in cost of your interventional drug divided by difference in benefit of your comparator. So when you do this calculation, you will get 1.7 for ICR ratio for SFD in FB when compared to TEM. And ICR for single FEV1, you will get 0.68. So how you have to interpret in a way that, see, you can see the calculation difference in cost divided by difference in effectiveness of intervention minus comparator. That is what difference will come. So when you do this calculation, you can calculate an ICER. So this interpretation, I will tell you in a simple way. You have to pay 1.7 monetary units. If it is US dollar, you have to pay 1.7 US dollar to get an extra symptom free days in FP group when compared to TF. And in terms of FEV1, if you want to get one FEV1, you have to pay 0.68 extra US dollar when compared to the TA. That is what the interpretation will come. So after all this calculation, there this article is told that FP demonstrated have an advantage over TA by exhibiting lower cost per improvement in lung function, per improvement in symptom control. So that was the interpretation. So what they said, FP is better than TA. So if you stop here in ICER, you can tell that FP is better than TA. So our pharmacoeconomic evaluation is over. Now our pharmacoeconomics evaluation is over. But that is not the end. You have to see whether the patient is affordable or not. So to know that patient is affordable or not, you have to do one more step, which is called it as incremental net benefit. So our cost effectiveness analysis is stopped at the level of ICER. But to know whether patient is affordable or not, you need to do incremental net benefit analysis. So when you do incremental net benefit analysis, you have to add one more term. You have to add one more term which is represented as lambda, which is also called it as willingness to pay. Here I say simple example. Simple example I will tell you. After I do a analysis of two treatment regimen, I got that to get one single extra outcome, I have to pay 5,000 rupees when compared to the drug B for a drug A. For a drug A, to get a extra outcome, suppose I say one example in asthma cases, to get one extra symptom free day, I have to pay 5,000 rupees. So here what is the effect? Effect is one symptom free day. Cost is 5,000 rupees. So there is a function lambda. If you multiply that lambda, that will be in terms of money. Suppose I say one example, lambda is 4,000 and your cost is difference is 5,000. If you keep lambda 4,000 into effect is 1, so 4,000. 4,000 minus 5,000, how much it is coming? Minus 1,000. So you are putting an effect of 4,000 or you are getting an effect of 4,000 by paying rupees of 5,000. Is it cost effective? You are getting a benefit of 4,000 by paying a amount of 5,000. It is not cost effective. That is why you are saying when this difference is less than 4,000, sorry, 0, the analysis is, or the drug is not cost effective. Did you get that point? Suppose my lambda is 4,000 and the cost difference is 5,000. That means I am paying 5,000 rupee to get the benefit of 4,000. That is not at all cost effective. So this is how we have to do a incremental net benefit. But this will be applicable when you go for a decision making. Otherwise, simply to do a cost effectiveness analysis, you don't require to do this incremental net benefit analysis. You can stop at a level of ICER. But to do a decision analysis, you need to consider whether the patient or payer is willing to pay that much amount of money, and accordingly you have to do a incremental net benefit analysis, and you have to, it's simple concept, don't think of too much analysis, simple concept. When I am ready to pay that much amount of money which is in difference, it will be cost effective. If I'm not ready to pay that much amount, it is not cost effective. That is a simple concept of incremental net benefit analysis. And now the session is open for you another for 2 to 3 minutes. You can ask any doubts till now.
Yeah, participants. Yeah, you can. Sir, you can go to. You can continue the session, sir.
Yep. So now I'll move into the third session. As I said you the before in the sessions, we have cost minimization, which I covered. The criteria
Sir.
first, both drugs should have the similar efficacy as well as the safety. So there will be a difference only in cost, and we'll be doing a cost minimization analysis. So in cost effectiveness analysis, there is a difference in terms of cost as well as the effect. So when is the maximum cost effectiveness will happen? When there is a higher cost with the higher benefit. When there is a lower cost with lower benefit, I said you a clause. And when there is any other condition comes, we don't do any analysis. We'll directly decide whether the drug is effective or not. We'll be move forward. And when you look into the cost utility analysis, it is almost similar to the cost effectiveness analysis, or I can say it is a sub part of cost effectiveness analysis. But there I took the natural outcome or clinical endpoint. But here I will be taking any utility outcome, or we call it as humanistic outcome. That is the only difference from the cost effectiveness to the cost utility. Rest all will be similar to the cost effectiveness analysis. Here also you will be calculating a CER, you will be calculating an ICER, you will be calculating an IMB. But only concept is that instead of natural units as an outcome, you will be taking a utility outcome, or we call it as quality of life, or we call it as any humanistic outcome. That is the difference between cost effectiveness and cost utility. And I said always, we always the pharmacoeconomist, he will go with the cost utility than cost effectiveness outcome, because when you analyze only effectiveness, you will get to know what is he getting out of the treatment. But you cannot tell, or without doing a cost utility analysis, you cannot analyze how much comfortable he is with the treatment. You are giving a best treatment, giving much as pain. That is not a ethical way. So we always prefer to go with the your cost utility if there is a possibility. Otherwise, we will confine into the cost effectiveness analysis. So I'm moving to the cost utility analysis. It is, as I said, it is a subset of CEA, but outcome will be measured in terms of QALY or any other set of utilities measures. Instead of QALY, we have DALY, we have LYY. I will take you, if possible, that each and everything. So here only difference, instead of clinical outcome, we will be going with the utility outcome. So when you are going to the steps, there are majorly 4 steps in calculation of calling. The first step, we should develop a description of each disease state or condition of interest. And second phase is choose the method of determining the utility. And third one, as first time Siddhant asked a question that who will be going to determine the utility. Here I will discuss you clearly who will be going to determine the utility. The final one will multiply this utility with the length of year for each option, and finally we will calculate the COLI. So depending on the COLI, we will do an ICR calculation, and finally we will decide whether the drug A or B is effective when compared to the other alternative. So the cost utility, the step one, as I said, we should have a accurate health effects for everything. As I said, in effectiveness analysis, we will be confined to a single outcome. It can be an intermediate outcome or it can be a final outcome, as I discussed with you in the previous slides. Intermediate outcome will be measuring every day or in alternative days or once in a week or something, whatever it is. So that is intermediate outcome in clinical outcome. But when you come to the final outcome, there will be a single outcome which will happen once in a while. So that is death or myocardial infarction or anything like that. That is intermediate or final clinical outcome. But when you come here into the utility analysis, you have to specify each and every outcome that can be experienced by the patient or which can be influenced the outcome in the patient when you do a intervention. Give me a moment, I will just connect the charger. Yes. So here I say one example. As I said you, the health status, different health status we have to define. As I said you one example, suppose I am doing one intervention in kidney dialysis patients. So when I am doing a hospital-based kidney dialysis in a patient, there will be so many health issues. One example is tubing insertion. I have to put a tube according to the dialysis process, whether it is hemodialysis or peritoneal dialysis. Depends on the dialysis nature and dialysis methodology. We have to insert a tube. That is the first kind of health effect or health intervention what we do in a hospital-based kidney dialysis. And because of this tubing insertion, he will be restricted his movement. He will be restricted his movement. That will badly affect his quality of life. He cannot move out or he cannot do anything else for another two hours or whatever, how much time it took for a kidney dialysis. So that insertion, because of that insertion, his restrictions to move, that is a kind of utility measure which you have to take care here. So this is the difference between a humanistic outcome and a clinical outcome. Third one, chronic discomfort. Obviously, you will have a discomfort. You can't but be bedridden for a long time and all those things. It will be discomfort. So all these things we have to take care in when you are assessing a utility measure. That is why I said always go with the cost utility analysis instead of going for the cost effectiveness analysis. Okay. So now the question is, as I said, you the first step, we should define each and every health status of the patient when I do an intervention. Next one, I should calculate the utility measure. I should calculate the utility measure. Usually, not always, usually we have three measures to do a cost utility or sorry to utility measure. We have majorly three scales or three methods which we follow usual practice. The first one is rating scale. As you all will be heard of our visual analog scale. I hope you guys are heard about visual analog scale which we use for pain and other things. It's a 10 scale or 1 scale Likert scale which is available to assess the pain. So similar where we will have different rating scale which will have a scale of 0 to 1. That is what we use as the first method for rating scale. The second one standard gimbal, third one is time trade-off. So I'll take you one by one methods. So you can see the visual analog scale, you can just see that if patient is not having any hurt or he is completely fine with it, he can mark it as a 0. Or if he's having maximum heart or worst condition, he will mark it as 5. So this will be easy for you to give to the patient so that it will be easy for us to understand how much pain he is having. I can't say that he is having 0 pain. Only he can say that he is having 0 pain. We don't have any pain. Sometimes he'll say, I have the pain. It will come in between 2 and 3. So he can mark accordingly. So this is the one where how we use it to take the utility measure from the patient. So it depends on the variation. So it depends on the condition to condition, the scale and its markings, its points and everything will be changing. And ulta also happen. Ulta in the sense, suppose here it is pain. So no pain is 0 and unbearable pain is 10. So 10 maximum is giving to the worst condition because it is a disability. This is where Colley and Daly is differed. Quality adjusted life years. That is Colley. Daly, disability adjusted life years. So the difference between Colley and Daly, Colley, the maximum point will be given to the best good health status. But Daly, the maximum point will be given to the worst health status. So here it is a Daly. You can see that unbearable pain is the maximum score, so it is a disability. But if you take a health status, I am asking how you feel. Are you fine, comfortable? So if you say 10, I am completely comfortable, that will be the highest score for his Colley. But this scale, pain scale, you can choose for the Daly. So it depends on the condition to condition, the markings, the gradings, and all the measurements will be changing. So, okay. And it depends on the disease or depends on the condition which we are analyzing, whether we should choose Colley, whether we should choose Daly, that also will be changing. Second one, time trade-off. These are another way to use the uh, calculate the utility measure. So here give maximum attention. I hope I can finish it in single shot. You see there is an x-axis as well as there is a y-axis. Be careful, just give maximum attention. There is an x-axis and there is a y-axis. X-axis, you can see years of life he gained, or the years, time years, that is will be marked as in the x-axis. When you look into the y-axis, there will be marked as the health. Health status will be marked. So now, I'll give you a simple example. I have two intervention. I have two intervention. A patient came to me, a medical doctor, whoever is this, a patient came to him and he said that I'll give you two options. One option, I will do a surgery for you. You will get complete health. Suppose the person is met with an accident. I'm giving him two options. One option, he is in the last stage. So I give on if you do a surgery, any surgery, some surgery, I don't know what is the name, some surgical procedure I'm giving as an intervention. I said to him, if you do this so and so surgery, you will get 100% complete health back. But your life will be reduced than what you expect. Is that one first option is clear? The health decision maker will say, I will do a surgery for you. You will get 100% complete health back, but that will reduce your life of years. That will reduce your life years, not the quality. Quality will be 100%, but years of life will be reduced. That option you can see as a symbol dot. You see the full health with X. Actually, his life is supposed to be at a T. But if you do a surgery, he will get the full health with a reduction in the his quality of his years of life, that will become X. So first option with the full health till X time. Second option, I don't do any surgery, you can live as like this with the this much amount of health. He may have pain, he may have all other discomfort or whatever it is, but he can live full length what he is supposed to have. He can live full health supposed to have without having a complete health, without have a complete health, partial health he can live full time, or else full health partial time. These are the two options. So I hope you are clear with this methodology. So we have one option is X, another one option is T. So if you divide X divided by T, you will get the utility score here. So these conditions will be used in that so and so condition where this is applicable. Am I clear? I just want to pause for 1 second. You have to look here. Two options. First option is full health, partial years of life. Second option, partial health, full years of life. So the person or the decision maker has to decide which method he want to go, which, whether we should do the surgery or we should do the intervention or not. So that call will go to the next person. So if this is the methodology which you are using, you can calculate the utility as X by T here. This is the second method. First method I said writing scale, according to him he can do, and the second method I said time trade-off. So here if you calculate X by T, you can calculate the years of, utility. I'm moving to the next slide. I hope this clear, simple, clear. Next slide is standard gimbal. Similar way. I'm giving an similar alternatives. I'll say to the patients that I'll give you two options. First option, I will do a surgery. After doing surgery, first option is alternative one, I will do a surgery. There are chances that 50% you will die. Other 50% you will come back into the complete health. Two option. First option is I'm giving you a surgery. Out of this surgery, you can come back completely into full health, or you may die. That is the first alternative. Second alternative, I'm not going to do any methodology or any kind of intervention. you can leave as such with you what you have right now. That is the second method of alternative option I am going to give. So out of these three called, patient or decision maker can choose any one option. Accordingly we will move to the his calculation of utility. So sir, I just put a pause for another 2 minutes. I can just go through the first method is visual analog scale or rating scale. Second method is time trade-off, and third method is standard gimbal. So these are the three options. So just have a look. Any doubt you can ask me right now. Please be understand. Otherwise, it will be difficult for you to interpret when I calculate calling. Is there any doubts? If no, I will move to the next slide. As I said, you the first step is what we will do a description of each health status. Second one, we will calculate the utility. Third one, as I said, you there should be someone who can determine the utility. As I said, you I am giving an option to the patient. You can choose any one out of this. If patient is able to decide, if patient is able to decide, he will choose which one I want to go with. Suppose the patient is not able to go with that, what will happen? We'll ask their family. So the family can choose, depends on their money or whatever the factor which they have. They can choose whether they should go for intervention A or intervention B or nothing. So that is the second option. Third option, the healthcare professional, doctor itself, according to his physical condition or other conditions, he can decide whether to go with the surgery or not. Suppose I'm giving an intervention to the whole generic population or generic public intervention I'm putting up. I can't ask each and everything. So I will catch some set of people who can decide whether to go with that or not. That's what we do in the normal public kind of health related aspects. So these are the people who will be choosing the subjects or will be choosing which methodology they should go. So which utility measure they should go. So this is third step. Once you fix which utility you are taking, you will be calculating the COLI, and once you calculate the COLI, you will be doing an ICER, and finally you will be deciding whether you should go with that intervention or not. Here I'll give you an example, or else I will take you to the another slide.
See, sir, is there any problem?
I mean, is this slide is
Audible?
visible? Health related quality of life. Is it visible?
Yeah, yeah, yeah.
Yeah. So as I discussed you how to calculate quality, these all things I already discussed with you guys, and I said you quality of life. Quality of life is an aspect. I'm just deviating from the economic evaluation to the calculation of outcome research. As I said you before, only was the like combined one. So I'm just taking you this aspect. What you can do here, as you know, quality of life, as I said, it is person to person perspective. My quality of life will not be same for the Rausa. Rausa's quality of life will not be same for any students, or our quality of life will not be same for the Ambani. So each one's perspective, her or his quality of life will keep on changing. And similarly, when we are dealing with the patients, each patient perspective, his quality of life will be differ. If you ask a cancer patient who is having a chemo for a long time, who is on the four walls of a hospital, you ask him what you want. He may say that I just want to go out of this hospital. That is his quality of life. What is the satisfaction? What he get? But that may not be same with me, or that may not be same with someone who is a common people. So quality of life will be differed from person to person. So any aspect of life, what is my level or individual level of expectation, how good his life to be, that is called it as quality of life. It is an individual perspective, or it is an individual perception of their own life in terms of all aspects of his life, how his life has to be. That what it is called, it is quality of life. If you look into the WHO definition, it's a very big one. Individuals' perception of their position in life context to the cultural variable system which they live in relation to the goal expectation. So it cover all aspects of your life. That is quality of life. But when you look into the HRQL, health related quality of life, there are only 5 aspects which we majorly take. One is his physical health, the second one is his psychological health. Third one is level of dependence, how much he is dependent to others, and how much he is socially well-being. There is a major aspects, 4 aspects which we take in the HRQOL. So I'm not talking much about all these things, and you can just skip this. Hello.
Yeah, tell me, sir.
In between, someone spoke. Yeah, then sir, I'll move it towards. So this is what why we are using the HRQL, health related quality of life. As I said you before, to do a cost utility analysis, you need a HRQL, health related quality of life, or is COLI or DALI. So here the question is that major 3 aspects why we are doing the health related quality of life. First one is discrimination, second one is evaluation, and third one is prediction. So discrimination means to know what is right now happening with that particular population, how much is their quality of life. That is discrimination. I'm going to my hospital today. There are a group of lung cancer patients. I'm giving a health related quality of life. There are fact scale and all for cancer patients. And if I give a fact P scale to the young patients, and I'm asking them to mark down how much they are good in their life right now, that is called a discrimination. It's a cross-sectional survey. Right now, I'm doing just to know what is their current status. That is the one application of any health-related quality of life measure. Second one, evaluation. Today, I measured what is their quality of life. Tomorrow, I'm going to give some intervention to them. I'm giving some kind of moral support, or I'm giving some kind of good things to them which they may feel happy. And after that, I'm taking a one more analysis of the same scale. That is what call it as evaluation, so that you can see how much there is a change from the previous one before intervention to the after intervention. That is the second application of any HRQL measure. Third one, prediction. Once you have this one before and after evaluation, you can predict how much they are satisfied, or how much they can score, how much you can have a good outcome when you give such kind of intervention. Because obviously, when psychologically they are good, when socially they are good, when they are physically good, when they have a good quality of life, obviously the treatment will be effective. So without calculating the quality of life, giving a treatment in such kind of patients is not that much appropriate. That is why you should do a quality of life in best, especially in those kind of patients. So this is the major applications of HRQL. Then I'm moving to the type of HRQL. Basically, we have 2 type of HRQL measures. One is generic, next one is disease specific. As you all know that generic means generic. I'm just asking about how he is generally, in the sense how his overall well-being of his life. I'm not asking anything about his disease. I'm not asking about anything his medical condition. I'm just asking how you feel right now. That is generic measures of your health related quality of life. When it is going to the disease specific, it will be something which is related to the disease. There are different scales for each and every aspect. I'll take you one by one. So this is the same thing I said you. uh, you can see the same thing. I'm repeating the slides and different methods how we are going to calculate. Yeah, here you can see when you look into the general health status, we have different scales like MOSF. I hope majority of might have been heard of SF12, SF36, and SF36 version 2. It is medical outcome study short form survey. It is SF12, 12, there is 12 questions in that. SF36 is advanced version. There are 36 questions there, and they have a version 2 of SF36. So another one is EuroQL, EQFID, another one is quality of well-being by WHO, and sickness impact profile, Dartmouth COOP. These are all different generic measures which is not related to any disease, just to know what the patient experience right now, what is the health related quality of life. When you go to the disease specific, these are all different scales, but each one you may have to take the specific permission from the authorized authority to use this scale. If you look into hypertension, we have physical symptom distress index. We have subjective symptom assessment profile for hypertension. BPH, we have American Urology Association symptoms scale, AUSI. Then BPH impact index is the. Then asthma, we have living with asthma questionnaire. Then life activities like that. Each different. Say, like I said, cancer, we have functional assessment of cancer therapy, FACT scale. Then one more is the FACT P scale, which is specific for the other type of cancers. So these are all the different type of two measures which I said, generic and disease specific. When you go to the generic, we have about his general well-beingness or general health related quality of life. These questions will contain only about his like normal life, how you feel, whether you slept, like that kind of questions will be there. Okay. But when you go to here, it will be something related to the disease. Suppose you are using BPH, benign prostatic hyperplasia. If you use that scale, the question will be specific to urinary system. They may ask how many times you urinated today, whether you experience any pain while you are urinating. Like that, very specific to the disease aspects will be having here in the disease specific. I hope you are clear with the two different types of scales. One is generic measure, another one is disease specific measure. These are the advantages and disadvantages. I don't want to get into that. Then these are, yeah. Now you look into this. Before that, I just give a 5 minutes pause for you. You can just recollect whatever I said right now. Then you can just ask me if any doubts is there. Is there any doubts? If not, I will move into the calling.
You can move, sir.
So as you said,
Am I
now,
audible, sir?
yes, sir, yes, sir. So as I said you guys, first we calculate utility. So these are all the different measures to calculate the utility. I said you rating scale. I said you about this one time trade-off. I said you the another method also standard gimbal. Then I said you about different scales which are using HRQL measures. All these will be used to calculate the utility, but that is not calling. That is just utility. So now you have to calculate the calling. For that, you should have an approach which one you want to use in that. When I look into this aspect, you can see this is the first aspect of calling. You see here, just I said to you before, time trade-off method, the similar concept is here. I have intervention A, I have intervention B. If you give an intervention A, you will have the maximum. You will have the maximum quality of life, but years of life will be lesser. Okay? When you give an intervention B, the quality of life will be decreasing, but years of life will be increasing. Quality of life will be decreasing and years of life will be increasing. So this is the one concept of quality adjusted life. So here what we are doing, we are taking this part B with this utility score. Suppose I am giving B, be careful, okay, just have a look into this whatever I am saying and just follow me. A is there already in patient is having. Suppose I am not giving any treatment. Yeah, you consider as I am not giving any treatment to the patient. What's happening means he can leave, suppose 35. That green line is ending at 3, 5, right? So you suppose you calculate it is 35. If I am not giving him any treatment, he can have full length health. He can have full health of life, but he cannot live more than 35 years. Is that concept is clear? That is the concept of A. Second concept, B. I am giving an intervention, but that will reduce his quality of life, but he can live up to 55 or 60 years of life. So two concepts out of this, how I will calculate the QALY means, you consider this green line on the top of the HRQOL, it is 1. When I give an intervention, it reached up to 0.5. If I multiply this 0.5 of his HRQOL or utility with how much years of life he got? 25 years. From 35, if I go and extrapolate this, is up to 60. There is 25 years. If I multiply this 25 years into this 0.5 of health related quality, I can get a quality. So 0.5 into 25. 12.5 years of life he will get. That is what he is calling out of this treatment. Are you clear? The first concept of calculation of calling. This is first concept. Second concept, you can see if I give an intervention, you can see that both lines are starting from almost 1. Suppose it is 0.9. So there is no difference. There is no compromise whether you choose option 1 or option 2. There is no compromise in his quality of life. That means his utility score. So that is same as before. If you give intervention A or intervention B, his life is same. But his life years may change. If I'm not giving intervention, he can live up to 20 years. 2. If I'm giving intervention, he can live up to 40 years. But there is no alteration, there is no compromise in case of quality of life or in case of utility measure. So here the calculation will be, I will just subtract 40 minus 20, he is getting 20 years of life. That will be his quality, because since there is no change in this y-axis, I'm not considering that part. I'm just looking into the x-axis. But here there is a change in y-axis. That's why I have to look into the y-axis as well. This is how we calculate the QALY in simple aspects. So it depends on the situation to situation. It will vary. Next one, daily. This is a very nice concept. QALY is over in two aspects. One case you have to consider the utility. One case you don't have to consider the utility. Now, DALI. It is opposite to QALY. It is opposite to QALY. There I have taken quality adjusted life years. Here I am taking disability adjusted life years. In disability adjusted life years, you have a clear vision over here. I'll tell you. My calculation is starting from birth, left end of the birth. Okay. A guy is born. His life is expected to be 70 years. See the expected life years, it is 70 years. Okay. That is his expected life. The guy was living, and at the age of 30, he met with an accident. Can you see that orange shade starting? At the light of around 30, he met with an accident. Another 20 years, he lived with a disability, and he died at the age of 50. He died at the age of 50. Now, the calculation of disability is very funny here. I have to calculate YLD, years of life he lost due to the disability. That is YLD. Another one, I have to calculate years of life he lost due to the death. That is YLL. He's completely lost his life. Can you see that orange shade as well as some like whitish color? So I have to calculate YLD, which is years of life he lost due to the disability. Next one, I have to calculate YLL, which is years of life he lost due to the death. Now you see, birth was 0, expected life was 70. At the 30, he met with an accident. So obviously his quality of life was 1, right? His quality of life was 1. What happened because of that disability? He lost his zero point 0.2. He lost his zero point 0.2 utility. He lost zero point 0.2 utility for another 20 years. He lost his zero point 0.2 utility another 20 years. Right. So how much he is having utility right now? He is having a utility of 0.8. He is having a utility of 0.8 before he was 0. Sorry, 1. Now, what is happening means at the death, he completely lost. He completely lost. So I hope you guys are remembering when I said you visual analog scale or rating scale, I said you when you calculate DALI, the worst outcome will be considered as 1. The worst outcome will be considered as 1 and good outcome will be considered as 0. Now, when I calculate YLL, I have to calculate the utility as 1. So 20 years into 1, that will be 20. So DALI for 20 or YLL will be equal to 1 into 20. 20 is the years, 1 is the utility. So 1 into 20 is equal to 20 years. YLD, how much he lost? Utility 0.2 he lost. How much years he lost? 20 years. So you have to multiply 0.2 into 20. It will be equal to 4 years. So totally he lost years. DALI will be how much? 20 plus 4. How much? 24 years. Suppose we simply calculate how much we will calculate. 20 he lost due to his disability, 20 he lost due to the death. So there is a chance that we calculate is 40, but it is not 40. That is where the utility measure have an important role in the calculation of DALI as well as COLI. So here the calculation will be 20 plus 4, which is equal to 24 years he lost. That is what the calculation of DALI. I hope you guys are clear. If you are not clear, I'll just give a pause. You just have a look, then just try to understand, then I'll just continue. If you have any doubts, please unmute and ask me.
Hello. Hello.
Yes, sir.
Rashid sir. Sir, how this 4 came? 4 years, 20 plus 4.
Yeah. Is there any provision to write? Yeah, and I can annotate, right? Yeah. You see here, this person is born from here, right? His born was here.
Okay.
So it is 0.
Okay.
Died here. Suppose he is expected to be dead here.
Okay.
It is 70. Is that clear?
Yeah, yeah.
This is the basic calculation. So what happened means he lived up to 30 of age. Here it suppose his life is 30 age. Okay.
Okay. Hmm.
Now he met with an accident.
Okay.
So, as I said you before, in Quali calculator, call another person. Mute the mic, please.
Mute the mic. Other participant, please mute your mic.
So, suppose he met with an accident at the age of 30. He lost his utility score of 0.2. Is that concept is clear till now? He lost 0.2 utility. Clear. Then he lived another 20 years. Lived another 20 years. Once he dead, his utility will become completely 1 because he's having the worst outcome. So the utility is 1 now. Okay. Now, from 50 years of age, he's completely dead for another 20 years. If I calculate the DALI for this, I have to calculate the DALI for first YLD. I have to calculate YLD, then I have to calculate YLL. If I calculate YLL, I have to calculate the years into utility. That will become 20. Till here is clear. That person can unmute and tell
Yeah,
me.
yeah, sir.
Yeah. So till here I have calculated 20, right? I multiplied years he lost with the utility score. But here you see, he lost only 0.2 utility and he is living with another 0.8. So what I should do? I should multiply this 20 with 0.2. That will become 4. 20 into 0.2 will become 4. So total how much he lost? 20 plus 4, which is equal to 24 years he lost.
Okay, okay.
Now is it clear?
Yeah, yeah.
Is it clear? Anyone you can ask before I just remove the markings. Yeah, Prince, tell me.
That means combining both YLD and YLL,
YLL,
right?
you can calculate the DALI. Is that
Hello?
clear for everyone? If not, I can tell one more time. I don't care because anyway we are just dipping into it. So it is better to understand at least one concept. Is there anyone want to explain me again this thing? It's simple concept. Not actually, it's not simple, but it's a simple thing. Suppose we start his date from birth till the 70s expected the death. But what happened at the age of 30? He met with an accident and he lost 0.2. And suppose is 0 here. He got another 0.2 disability and he lived with 0.8 disability till his death and another 20 years he completed with this. So this is how we calculate how much it is, and that this 0.2 will be depend on how much burden he is having. Suppose he have a simple pain, we cannot give 0.1 or 0, give 0.001. if he's lost his one leg, we can give up to 0.2. So it depends on the situation, how much burden he is having, how much disability he is having. This calculation will be varying. So this is how we calculate the Quali and DALI. Anyone is having any doubts? This is some other methods of alternatives to DALI, but I don't want to take you guys there. You understand what is DALI? That will be enough for me right now. This is some more complex calculation of this DALI only. There is a HYE, health year equivalent. There is a willingness to pay. I already said you what is willingness to pay. So these I already explained you different scales, how to calculate and all those things. Then validation of when you prepare any instrument, there is a validation process, but I don't want to touch it right now. I'll go back to my economic evaluations. Yes, sir. Is there any doubt? Sir, can you just remove how these markings? I don't know how to remove that. Hello, Rao sir, are you there? Hello, sir. Can you help me to remove these numbers here?
Sir, am I audible?
Yes, sir. Can you help me to remove these numbers over there?
Hello.
Yes, sir.
Sir, after sharing, once you are shared share screen, no, in
Yeah,
PPT,
yeah,
so right side you can see annotation more is there. Annotation
yeah.
is there.
Yes, sir.
Click on annotation and delete that. So clear means automatically
Yeah,
it will.
yeah, I got it. I got it.
And beside there is more is there. Disable the annotation.
Yeah, I got it. I got it. Now it's fine. Now it's fine. Thank you.
Beside there is more. You can
Yes.
disable the annotation so that no one can write.
Okay, sir. No problem. Okay, thank you. So hope till now I'm clear with the concepts: cost minimization, cost effectiveness, and cost utility. Cost minimization, both outcomes are similar, efficacy, safety, everything is similar. Only difference in terms of cost. What we do, we will just compare, we'll decide which one is having lesser cost, then compare to other, we will choose the best one. Next one, cost effectiveness will have difference in terms of outcomes as well as cost, but the outcomes will be in terms of clinical outcomes. And cost utility we will have in terms of utility, and in cost effectiveness as well as cost utility we will be calculating ICER, incremental cost effectiveness ratio, and according to that we will be choosing after incremental net benefit which drug we should go for it. So here I stopped three analysis. Now I'm moving to the fourth analysis, which is cost benefit analysis. As I said in this chart, the cost benefit analysis, you have to convert even the outcome also into the monetary units. So the bigger question is that how I convert the amount in, sorry, benefit into the cost. That is the biggest question here. It's a simple concept. If you understand very well, it will be very easy for you. So this is having many advantages. Sometimes you cannot go with all those things. Only your option will be this one. Uh, so I'm just skipping all these steps. I'm directly moving to the concept. Yes. As I said you guys before, I just said you when you do any new kind of intervention, any kind of asthma clinic or any kind of coagulation clinic, you have to go with what cost benefit analysis. You cannot use any other analysis. You have to go with the cost effectiveness, sorry, cost benefit analysis. So here I am saying you an example of I am putting up a asthma clinic. I am putting up an asthma clinic. So when I go with an asthma clinic, what I'm going to do, I'm starting an asthma clinic for those patients who are having coming to the emergency. What I'm going to do in asthma clinic, I'm going to explain them all the patient counseling activities, or I'm going to explain them how to use the inhaler, how to use the spacer, how much time you should take a puff, or how much time you should hold 10 seconds, and all the steps I'm going to say them. Right. So when I give more interest, or when I give more clinical pharmaceutical interventions to them or patient counseling to them, they'll be getting educated. Obviously, they will be using it properly, and ultimately they'll be getting benefited. Right. Now, that benefit what they are going to get, I have to convert into monetary units. Cost here, whatever I am going to put to establish this asthma clinic will be considered as my cost. Whatever I am going to put for establishment of this asthma clinic will be the cost. I am I'm just taking a room for that. I have to give the rent. I have to keep all this, I have to buy all these spaces, dummy inhalers and everything. I have to pay for that. I have to keep a clinical pharmacist over there. I have to pay for him salary. And I have to keep one bench desk and all those steps there. So I have to give the payment for that. So all this cost, whatever I am putting over there will be considered as my cost. So one part is clear, whatever my budget, whatever my expenses to establish that clinic will be considered as my cost of the intervention. Now the benefit. benefit whatever patient is getting benefited out of that. So here I say example of asthma clinic. So suppose after my intervention, after my asthma clinic, if the patient is able to go 10 more days than extra what he was going before. Simple example, patient is having a duty in the bank, and because of his asthma, because of his breathlessness problem, he was not able to go for work for 5 days. He was not able to go for work for 5 days in a month, right? Next, after I give the intervention, after I give the intervention, he is able to go for work for another 3 days. That means he is missing only 2 days when compared to before. Before I start my asthma clinic, he was not able to go to the his working location for 5 days. After I give intervention, he is missing only 2 days. Other 3 days he is getting benefited. That is how I calculate my benefit out of these kind of interventions. Now, how I convert, he is getting 3 days benefit, okay, when compared to my before intervention. Now I'll convert into the monetary unit. That is the question. Suppose you calculate the patient, that particular person is earning rupees of 30,000 per month. Rupees of 30,000 per month. His daily income is 1,000. His daily income is 1,000. Before he goes to the hospital, before I start the asthma clinic, he was missing 5 days. So he was missing rupees 5,000 from his salary. Right. After I start intervention, he is missing only 2 days. So he is only missing 22,000. Sorry, he is missing only 2,000. Other 3,000 he is earning. Other 3,000 he is getting benefited. This is how I convert my benefit into the monetary units. And the question is that how I will say that my intervention is cost benefit. You calculated the cost, how much ever the amount of money you are putting for establishing that asthma clinic is your cost. How much per patient is benefiting? 3,000 per patient is benefiting. That is your benefit. So suppose you calculate for per month, you are all together, you are paying rupees 50,000 for your maintenance and all those things for your asthma clinic. You are paying 15,000, 1 5. Okay. Now your per patient is benefiting 3,000 per month. Suppose you have 10 patients in a month. You have 10 patients in a month. You calculate that with the 10 patients. How much they are getting benefited? 30,000 per month they are getting benefited. And for that intervention, I am putting up only 15,000. I'm putting up only 15,000 and he is getting a benefit of 30,000, and that is where I say my intervention is effective. Suppose I am spending 45,000 and he is getting benefited only 30,000, then I cannot say that my intervention is cost benefited. Are you clear? When your benefit is overweighing your cost, what you are inputting, that time you can say that your intervention is cost beneficial. If your cost is not overweighing, sorry, if benefit is not overweighing your cost, then you cannot say that your intervention is cost beneficial. The same thing has been explained here. Then as I said, you the daily wage rate per patient per day. Similar way you can calculate the yearly wage, or depends on the intervention methodology, it will be changing. And missed work days, missed work, all these things I just explained to you as well. Then this is how I will calculate that. And finally, the same way there is a willingness to pay. That concept is different. I don't want to explain you here. So I will tell you how to calculate whether it is benefit or not. There is net benefit calculation as well as there is benefit to cost ratio calculation. So net benefit means, as I said, you just subtract how much benefit you are getting from the total cost. Total benefit I got 30,000 in the example which I mentioned you right now. And total cost how much I put? 15,000. So it is more than 15,000. So it is equal to 15,000. That means more than zero. So you can say that it is effective if the value of difference in total benefit minus total cost coming more than 0, it is beneficial, cost beneficial. If it is less than 0, it is not cost beneficial. Clear? Now, benefit to cost ratio. Similar way, you divide cost to the benefit or benefit to the cost. If it comes cost to the benefit ratio, cost divided by benefit ratio comes above 1, it is beneficial. If it is less than 1, it is not beneficial. This is how we calculate the outcomes. Okay. Now, this is one example for cost benefit analysis of roseolitis vaccination for senior pharmacy students in the United States. This is a published literature. If anyone want a copy, I can share them. Now, I have explained you all measure for clinical evaluation or pharmacoeconomic evaluation, which is cost minimization, where both drug will be considered as same benefit or same effect, only difference in terms of cost. Second one, cost effectiveness, where outcome will be calculated in terms of clinical outcomes, and we will be doing calculation of ICER. Cost utility, where I will be calculating COLI, DALI, or any kind of utility measures, and I will be checking ICR and I will be telling whether it is cost utility benefit effective or not. Finally, cost benefit, both will be converted into monetary units, and I will be calculating net benefit ratio or net benefit outcome. Then I will be deciding whether it is cost beneficial or not. This is about 4 major aspects of pharmacoeconomic evaluation, and one small analysis is cost consequences analysis. This I already explained you in the first stage of cost effectiveness analysis, where we'll be just listing out what was the total cost and what was the total outcome, and that simple calculation of comparison is called it as cost consequences analysis. There is no other calculation or things. We just list out how much was the benefit, how much was the cost for each intervention. Now, cost of illness. This is a kind of epidemiological related issues. Suppose I want to now coronavirus is running like anything. It is a like a deadly pandemic right now. So if I calculate how much burden this coronavirus infection had in India, how much cost resources it has been utilized in various aspects. If I just calculate the overall summation, that is called as cost of illness. How much total economic burden happened because of that particular illness is called it as cost of illness analysis. The best example, as you all know, there was a situation where Nipah virus infection was happened in Kerala. So if you go to the WHO, you can see how much was the burden of Nipah virus in India, and this is a link for that. So there they have done a cost illness analysis of Nipah virus in India. So they have said total of this much amount of money has been spent to treat, prevent, prophylaxis, management of Nipah virus infection. That is what cost of illness analysis. Overall amount or overall cost spent during a particular pandemic of illness is called it as cost of illness. So this is here I have ended up with all the types of pharmacoeconomic evaluation, and I would like to share your opinions or any questions or anything right. If any participant is having any question, you
Hello.
can just put it up.
So am I audible?
Yes, sir.
Rajit sir, am I audible?
Yes, sir. Yes, sir. Please.
Hello, am I audible?
Yes, sir. Yes, sir. Please speak. Rao, sir, please speak. Either you are audible. Sir, you are not audible right now. Your phone is mute, sir.
Is it audible now, sir?
Yes, sir, you can speak up now. Please speak, sir.
So it's participant time to interact. Muhammad Rashid, Alas.
So you have a look whether any question has been raised from YouTube also. There may be chances. Yeah, the discussion is open for you guys. If you have any doubts, you can please put it up. So you are muted. You are muted, sir.
Sir, is it
Yes.
audible now?
Yes.
Nani Babu,
Sir, tell me, sir.
so why don't you interact with sir? You have got such a personality, but the participants are, I don't know whether you understood very well.
Yes, sir. Very
Not
elaborated session.
because
Very
I've
good.
been waiting for Rasi sir class for our students regarding pharmacoeconomics and epidemiology.
Yes, sir.
Usually, usually family students can take good guidance at Rasi
Yes,
sir,
sir.
but means he did some days in faculty as assistant professor in Alexandria College of Pharmacy. But
Yes,
again, he
sir.
shifted to the research scholar, and again he shifted to industry. So you can
Yes,
understand how much passion he has.
of course, sir.
So really, it will be benefit for our students and career also. So who expects more salary in Farm D? So in pharmacoeconomics, in-depth subjects, how systematic review and the meta-analysis, and Thare has said different analysis, cost analysis studies.
Yes, sir. Students can post some good questions
Yeah, you can
regarding
interact.
research in economics. What are the papers to be published in economic area? How they're going to be useful in their career growth? They can put some questions. They can interact. They can get some clear answers in the research area of pharmacoeconomics. They can boost up their career by interacting with sir also.
Yes, sir. To addition to that, not only pharmacoeconomics, if you can have to ask any small questions from your mind regarding any of your research, you can put
Yes,
up
sir.
that also because I'll be able to have happy to answer that if I know. Otherwise, I'll get back to you. Never worry.
Yeah,
Any kind
Yeah,
of
surely, sir.
questions related to your
Yeah,
research.
students, see, please make it very fruitful because sir is very much um, good in pharmacoeconomical area. Sir is saying that he can answer. If not, he is going to be get back with a clear picture of answers what you have been asked. Uma Maheshwari, Shruti, Soumya, Yogita, Sahiti, Sivaraj, others, Ramya. You can ask any questions related to research, not only sticking for pharmacoeconomic area. Right? Please try to
I have
interact.
questions, sir. Hello, sir. I have a question.
Yes, please.
Uh, means in pharmacoeconomics, what type of research you are doing in Manipal, sir? How they are supporting you?
Yes, please. Uh, right now, not only in Manipal, across the India, we cannot see much pharmacoeconomics evaluations.
Yeah.
Yes.
So even I was behind to complete. I wanted to do in pharmacoeconomics only that time. That's the reason I joined as assistant professor and I tried to get it some data. I mean knowledge on that. So right now in India, basically the best type of pharmacoeconomic evaluation which we can do is cost minimization analysis. Because India, you know that we have a well-established system of branded drugs as well as generic drugs. And as part of many other environments, we are getting towards the use of generic drugs in
Yes.
some diseases basically, as well as there are some diseases where there is government research, government fundings also for the patients. So you can have a comparison analysis between these two aspects, uh, between generic versus branded, that is the symbol analysis, or else you can have an analysis among those patients how much they are paying, those who are getting the benefit from the government or not getting the benefit from government. That is the simplest analysis which is best feasible for us right now in India. Otherwise, right now we are looking towards the cost effectiveness analysis. But as I said, you all these utility measurements and other cost effective cost measurements, we don't have a system established in India. So right now, what I'm doing means I'm like adopting the systems of UK. Right now, I'm adapting the systems of UK and I'm moving forward with their own guidelines. But hopefully, another 10, 20 years, we can expect. I think PGI Chandigarh, I think PGI Chandigarh and NIPER and all is working very nicely on this area, developing Indian guidelines.
Okay. Yeah, one more question is what you suggest about means HCOR and means who are providing some internship in marksman and AMTZ. How does it help for our students?
Health economics and outcome research is the wonderful area which will be boomed in another 20 years, I can assure you. And what basically students will understand that if they are good enough in understanding the statistical part. You
That's
know,
what.
right, Novartis and other companies are not using big hi-fi systems for, they are using all everything in simple Excel and all only. So all this calculation, whichever I said to you, if the students are able to interpret in a proper way, or they are able to correlate one by one how it is, there is a things which is called it as decision, and actually I skipped it. If I say that it will be heavy for the students, there is a model, Markov model. You see, I just show
Yes.
you. There is a decision tree as well. If I compare, as I said, all this analysis, after all, I said you decide. Decision will go according to this tree. So you can see there are two aspects. One is a drug. Drug is effect. Success and failure, you can see there. Whether there is effective or not. Along with there will be chances that the patient may have the side effect, and each one will have its own utility, its own measurements, its own probability, its own cost for the treatment. So all this combining only we will do a pharmacoeconomic evaluation. So if they are good, if they are very good in interpreting all these steps along with some basic idea of statistical analysis, they can go towards the core pharmacoeconomics. Otherwise, if they are good enough in doing publications or in terms of good writing, they can move towards the systematic review and meta-analysis. That's another good area of outcome research. So it depends on the students' capability and kind of training what they get from the industry. It will differ because all industries, as per my knowledge is concerned, in India, none of the industries are completely working on core pharmacoeconomics. It will be depends on the company policies and depends on the client's activities. They will be taking part by part. If one company will not do any all analysis, they will be more focusing only one analysis, maybe CEA, maybe CUA, maybe other analysis. So it depends on the company policies, it depends on the exposure what they get, they can excel in their career. But I am sure that they'll be able to achieve something if they have kind of training from the industry.
Sir, I have a point here. Yes, yeah, Mohana, you can interact.
Hello, sir. Very good evening. This is Mohana. I'm from the intern. So, firstly, your presentation is really awesome, sir. I have been listening from morning, and I would like to ask something regarding my project. So, I'm doing a project on diabetes quality of life, comparing quality of life in diabetic to diabetes patients among rural and urban areas. So, uh, in what way I can excel my project topic, sir?
Yes. So you will be doing a quality of life. Which tool, may I know which tool you are using right now?
It's WHO quality of life scale, sir.
Yeah, WHO quality of life scale. Okay, great. So from Indian aspects, you can go into two, three different aspects about this project, what we are doing. The best way I say you can compare the quality of life of type 2 diabetes mellitus patients which are staying in urban versus rural. That is the one way you can just compare between the quality of life of patients who are staying in urban area who are staying in the rural area. Then you can see on which aspect even WHO questionnaire will have different set of demand dimensions. They will have like psychological health, they will have different health sector like that, they'll have different domains for that. You can see which domain the rural people are good, which domain the urban people are good. If I say one example, there is chances that rural people will have good social environment or they may have good social health than compared to the urban people. But urban people will have good amount of facilities or good amount of payment scale when compared to the rural people. So like this, what you can do, you can have a simple comparison analysis between the rural and the urban. Next thing what you can do, if you are able to incorporate the cost, if you are able to incorporate the cost into this, you can check how much there is a variation for the treatment of type 2 diabetes mellitus in rural area and in urban area. When you are comparing, again you can check in which aspect there is a more amount. Maybe the drug will be same, medical cost will be same, but the physician charge may vary. Their other treatment charge may vary. So you can have a simple analysis on what aspect there is a variation in the cost. If you are imparting the cost, or if you are only looking into the quality of life, you can check which dimension of quality of life there is a variation between urban and rural area.
Yeah, sir. Thank you so much. I have done this, sir. So I can add this cost analysis for now.
Sure.
Also, I have another topic serious mental illness, sir. I'm
Yes.
comparing quality of life in
Yes.
different mental illness conditions like schizophrenia and
Great.
others.
Great.
It's like I'm comparing this in government hospitals as well as private sector.
Great.
So, to what extent this can be a good thing, sir?
Yeah, it's a very good study, but first thing you have to get a conflict of interest from both sides, from the
Yeah,
government as well as private.
yeah,
Because when
yeah.
you go for the publication, you should not have any conflict of interest from both sides. Okay,
Yeah.
so that's the first thing. Second thing, if you are choosing, you while you are writing your manuscript, maximum try to avoid any statement which is conflicting. There will be findings, but you have to be very careful while you are publishing. Otherwise, the study is good if you have a good support from a government side as well as the private sector.
Yeah, sir. Thank
But
you
these
so
are
much.
some issues, as you know, from our own area. You have to be taken care. Otherwise, the study is very good.
Yeah, sir. Thank you so much.
Yes, thank you.
Sir, I have one question here, sir.
Yes, please.
Sir, is there any organizations or any bodies which are offering any short duration of internship in the area of economics or epidemiology so that our students can get
You want me to let
absorbed?
you know the courses or direct internship?
Like any short duration of internship in the areas of
The
epidemiology
best,
or economics?
the best website to search that is ISPOR, ISPOR,
Ah,
International
yeah, yes.
Society for Pharmacoeconomics and Outcome Research. If you go there
Yes,
is
sir.
one separate section only for career. In that career, if you go, you can see the list of companies as well as list of institutions which provide the internship activities on
Okay.
base to base, how much payment they will give, which country they are recruiting the students, everything there will be there. That is the first best website I can suggest you. There will be
Okay.
international as well as Indian in that. So if last time I think when I finished my farm, I just had a look over there. Then I found even our Pfizer and all companies are providing in Ahmedabad or some other areas. So what they do, they will put up to the ISPER and ISPER will link these people. Because ISPER will have hundreds of CVs of students as well as the trainers, as well as other people who are involved in the pharmacoeconomics. So ISPER can suggest the best people to them. So I feel ISPER is the best website where you can find the opportunities of pharmacoeconomics internship as well as the short course because that is so authentic, 100% authentic.
Yeah, we have as per student chapter as well as regional chapter.
Great, great, great. Sir.
So our
Actually,
student,
I feel in India each college should have an ISPER. At least the best thing, my personal experience, I say, I learned the communication skill from ISPER. You can learn the communication from them, how to put up a mail, how to do a proper mail to any authorities or anything. So I wish all Indian students should involve in the international related activities. That's the one best thing which we can do, so that we will get to know the atmosphere of international kind of things and how they are being with people and how they are communicating with the people. All those things we can learn from them. And if possible,
Yeah.
all students should go attend the international conferences and other webinars. Are hundreds of webinars are freely available from WHO, UMC, ISPER and everywhere. So we should attend it, all those things.
Yes, sir. Yes. Thanks. Sir.
Yes.
Okay. Any students? Any other?
This is my,
Can
you
you?
can connect me through this mail or else even I am available in LinkedIn also. So this is my
Yes.
connection, so you can just have a look. And I suggest you one book which is Karen L. Rascati. It is very nice book which if you want to learn about the essentials of pharmacoeconomics.
Which
so am I audible now?
Yes, sir.
yes, sir. See the book name.
Hello.
Yes, sir. It is Essentials of Pharmacoeconomics by Karen L. Rascati.
Okay. Okay. Thank you, sir.
Thank you, Mr. Mohammed Rashid. You have spent your valuable time with us. So I hope our students have understood very well. I don't know, means I can understand the economics. One day you cannot make miracle, as you mentioned. So you have to means you have to go in deep knowledge and practice. So then only they can come with the small information. So they can make some titles and they can make the projects. Even some students are doing some, they're trying and some who are supported in HU or health economics outcome research from Delhi and Vizag, aim to get Andhra Pradesh Meditech exam.
That's
Some
great.
people are supporting our students. Still, they're in dilemma. Still, we are not reaching such a way. So surely we'll follow your guidelines and surely we'll communicate you further.
Sure, sir. Sure, sir.
So thank you, doctor. We are going to become a doctor shortly. I don't know how much time it takes. So still, I've been before that, I'm wishing you all the best.
Thank you. Thank you
So
so much.
thank you, participants. Thank you all participants. You have interacted well. So Sar will be touch with you. It's not some thing that is Sar is for webinar purpose. Sari has knowledge, industry oriented and as well academic oriented. So feel free to ask anything, or you can mail to Sara has given mail ID and contact number. So even you can mail me, or I can forward to sir. So sir, surely you have to provide your services to our students. You can
Definitely, definitely to all students across the video. I'm happy to do that.
Yeah, you have regional chapter as well as the student chapter also.
Sure,
So
sure.
we will communicate to you, sir. Thank you very much. Thank you for participants. I'm ending
Thank
this.
you. Thank you so much. Thank you so much. Have a great day.
Okay. Okay. Last but not least, I think participants are looking for a certificate. So certificate I'm going to keep on YouTube. I did not keep it. I may keep by evening 5 o'clock. So what are the session you are able to see? That link below that description is there. So in that description, you can find a YouTube feedback link. So by clicking on that, you can get your certificate. Okay, everyone and all, thank you for the participation.
Thank you, sir. Thank you also.
I'm ending the session. Thank you, Anand.
Yes.
Thank you, sir.
Thank you, Rashid.